Hi, Aileen and everyone.
Hi. Hi.
Well, welcome everyone to the November George Eliot Board. Delighted to start off this meeting with the IXL Awards, and delighted to have the theatre team with us. But Catherine, do you want to read out the commendation so we can all celebrate the lovely IXL Award for the team?
I do. Thank you, Russell, and thank you for the theatres team for joining us today. I think we can say that you have got one proud manager here who made this commendation for you. And what I just want to do is so that all the board and the public who've joined us today can hear what Paula had to say about you, because you have done a lot of hard work through a lot of difficult periods. So it's really important that we all hear her commendation to you all. So what Paula wrote in her nomination was, the theatre team have continually worked hard over the weekends from May right up to the end of September. They've worked through the backlog of patients waiting for surgery, and we're now back in a reasonable position following the beginning of the pandemic. Staff have worked extra shifts, changed their off-duty, cancelled social arrangements, and literally staffed up to several extra lists per weekend. This includes anaesthetic, surgical scrub, recovery and support practitioners. This is an outstanding achievement, and the theatre staff have given all that has been asked of them. There has been a knock-on effect with sickness due to some of the specialised scrub working 7 days a week to achieve the target set by NHS, but this has been managed and they've been supported back to work as soon as they are well enough. The staff remain committed to George Eliot Excel values and work within them, and this has made a difference to the patients we've been able to treat so far. I am immensely proud of what the theatre team has achieved, and although we know we still have a way to go, the team are taking a rest from elective work at the weekends from the end of September, but are willing to take up the challenge again in a month or so. The whole trust is under pressure at the moment, and having staff like this who are always willing to go the extra mile makes my job as manager so enjoyable. So I think on behalf of the board, we'd just like to say a huge round of applause to you for a really well-deserved nomination. We are going to be hearing later on in the board what a difference you have made to patients who have been waiting over a year for treatment in many cases. That number has come down hugely because of your efforts and your team after all the things you did for us during COVID and for our patients. So just brilliant thanks and well deserved.
Thank you very much. Thank you.
Thank you, team.
Thank you.
Lovely to see you. You're very welcome to join us for the rest of the board. But if equally, if you want to go and have a cup of tea or just relax and do the day job, we'll understand. But thank you so much, as Catherine said, for all of the work you've done. It has made the world of difference to our citizens and to our patients and to their families. Take care, look after yourself, and thank you again.
Thank you. Thank you. Bye.
Thanks everyone. And Russell, we've got another IXL award to give out, and this is for Doug Meade. I don't think Doug's on the call, which is a shame because this is another great commendation. Doug is one of our porters, and this nomination was made by one of our senior doctors in training, Grace Pink, who's a registrar, who's just about to rotate out of the trust. But it's lovely to see people being recognised by their colleagues in this way. And what Grace has written is, Doug is not just a porter, he is a brilliant communicator with patients. And I've noticed on many occasions when he's talked to patients in a calm and reassuring way that has de-escalated their agitation. He shows compassion and care for the patients in A&E. There was an elderly lady who was confused and distressed on my night shift, and Doug sat with her briefly and calmed her down. He also spoke to a man with dementia who was agitated and walking off, which threatened his intravenous access, and encouraged him to sit down so that I could effectively examine him. I cannot commend him enough for his enthusiasm for his job and also his ability to go above and beyond to help our patients. This is all on top of doing an excellent job being a porter. So again, a huge round of applause and appreciation from the board to Doug, because that's just so great to see those caring values, outstanding caring in our team that we want to see so much.
No, thank you, Doug, and we hope you're able to hear the commendation, albeit digitally, in the future. Thank you very, very much. Okay, well, we'll move on then with the rest of the board. For members of the public to be made aware, we've had a very busy morning as a board, going through each of the directorates presented to us at a workshop about the progress they've been making on their various different initiatives, and it made me immensely proud of the progress universally we're making in terms of performance and culture to the betterment of our patients and their families. We have apologies from David Elchingham this morning, so Catherine is kindly deputising. Any new declarations of interest? Okay, I can't see any digital hands raised, so we assume not. The last set of minutes held on the 5th of October. Was everyone happy with the accuracy of those minutes? Please raise a digital hand if you wanted an amend. I can't see any digital hands raised, so we move on to the matters arising. Now, the first was, and a lot of these will be for next year and some of them for today, the board assurance framework, the high-risk target dates to be revisited by the executive team. That's for the start of next year. The under-delivery of SLAs and insourcing activity costs to be set out in more detail in the integrated performance report. We'll come back to that hack, but thank you. An update on rapid testing solutions to be given. Where are we with that, Stephen?
Yeah, so we've started the CEFID testing this Monday, so we're running it as a PDSA cycle with stroke and the other specialties. So I'll be able to update on board further around that, but it's in hand and it's happening. Okay,
thank you, Stephen. And then whilst I've got you, Stephen, the deep dive into shared service delays?
Yeah, I think that's got date to be confirmed. I think if people are agreed, I'll do that next month, obviously with my timeline, so I'd rather get that one complete myself if I can, so I'll do that next December.
That would be great, Stephen. And then revised figures around midwife to birth ratios to be included in the report. That's been done, so we'll come back to that, Daljit, thank you. And then format of future improvement reports to be reviewed to ensure it's succinct and reader friendly, and that's going to come back in December. Thank you, Jenny. Then the latest position regarding 38-day transfer performance. That's going to be in next month's IPR, Stephen?
Yeah.
Are there any other matters arising that I've missed? Please raise a digital hand. Stephen, you do realise we're not going to allow you to leave the building, albeit you may want to. So we'll move on then to Glenn's report. Glenn, how are you seeing things, please?
Thank you, Chairman. I mean, it's reassuring though this morning to see the layers of general managers that Stephen has created as well. So he can go and we'll cope without him because there's some really good people beneath him. I don't really mean that, Stephen. So just a few things from my report just to pull out. I mean, firstly, as you mentioned this morning, Chairman, the workshop. One of the things I love about the 3 boards meetings that we have is that we get the opportunity to share best practice across the group, and some of the things that we've looked at in those 3 boards meetings from George Eliot have been fantastic. And at our last meeting, we shared some things from each of the trusts, but we also looked at how we were preparing ourselves for winter. So within my report here, I highlight 1 or 2 things there. Obviously, a really concerning situation for the NHS in terms of the current performance against the urgent care standards. And probably the big indicator for us this winter will be ambulance turnaround times. And certainly it was great to hear from our urgent care team this morning how well we're doing on that. But we can't be complacent. We need to ensure that we do all the best practice that we know about, and some of which we've helped to shape, which is a real positive. We will be doing a comms campaign, which I refer to here, both internally and externally. The internal one is really just making sure that everyone is absolutely on top of their game throughout winter. It's been a hard 18 months for all of our workforce. So what we're not suggesting is we're going to be cracking the whip during winter, but actually we all know that if we do the right things and do today's work today, then we'll make it easier for ourselves. So that's very much what that campaign is about. I also referred to some of the digital innovations that are helping us through this winter. And again, we heard about some of those this morning. Over the page, I talk about the review that's going on capital allocations. That should conclude in the next few weeks, because the intention is it will influence the capital allocations across the NHS for next financial year. And the methodology for that will be slightly changed. From what I've seen, being on that reference group, the changes will be appropriate, and more importantly, the transparency that we are encouraging will help us when we then allocate the system level capital down to the individual trusts within the system. I then refer to the system oversight framework and revised segmentation. So we're going to be segmented in this 1 to 4 category, with 1 being the best performing systems and 4 being those that need support. So our overall integrated care system will be a 3, and we've been segmented 3 as a trust, and I explain there within this section the reasons for that, and also explain what we need to do to get ourselves into a place where we can move up a segment or 2. The main one we touched on this morning actually was our CQC readiness. And kind of unfortunately, because we are doing well on a lot of indicators, it's unlikely we're going to get the CQC rushing through the door to give us a new inspection soon. And I touch on that in my report, that we're gently encouraging them to come back, but they are taking a risk-based approach to their inspection. So we don't expect an immediate inspection. But on the other areas like the cancer waiting times, which we've seen some improvement, our financial trajectory, all of which have certainly moved in a positive direction. So I'd hope to see us moving up a segment soon. I then go into some directorate updates, urgent emergency care, radiology. I refer then also to showcasing the work of Mary Garth Ward on the Modern Ward Rounds Collaborative, which is excellent. There's a YouTube clip there if you want to see it. And then also refer to some staff engagement visits that are taking place with execs and non-execs. And just to reassure any members of the public, we will be absolutely stringent with infection prevention and control as we do those visits, but we will be ensuring there's kind of face-to-face contact between the board and some of our teams. And there's one other item I just wanted to add to the report, if I may, Chairman, which is we're about to face some industrial action from our IT teams with 4 days of non-consecutive industrial action. This links to what actually is a really positive development for us, which is the combining of the strength of the 2 IT functions between George Eliot and South Warwickshire FT. And what we're doing is putting them into the arm's length company that sits currently in South Warwickshire FT, but will be jointly controlled by the 2 boards. By putting it into the arm's length company, we create some efficiency. We create an opportunity for us to improve terms and conditions, to recruit more staff, because we have vacancies in those teams at the moment. And we create a stronger, better organisation. It's still very much part of the NHS, which is what I would want to emphasise here. National unions and regional union colleagues are concerned about any outsourcing to subsidiaries, and so we did expect them to oppose it. And the relatively small number of staff that are within the union, the vote has led to this action. Any ideas that staff have how we can improve the arrangements within those that plan, we are doing. So all of the staff are retaining NHS terms and conditions if they want to, and NHS pension. We've retained that for new starters as well. We will be have staff engagement and staff forums. And I would absolutely expect the company to be an exemplar employer like we are, but of course it will still be controlled by the 2 boards. And the other thing, just to be really clear on this, because I think one of the things the union have sometimes said is this could lead to the outsourcing, the selling off of our IT function to the private sector. That absolutely is not the case. This service retains within the NHS and is under our control, and we very much want to make it stronger. So the efficiencies that come out of this, we will be reinvesting in better, stronger IT that will help patients and help our staff to deliver care more effectively. So we'll ride the storm of this particular industrial action. I hope that we can, this will be the last that we'll see, and we move forward with this. We've risk assessed the impact of it on our services, and we'll minimise the disruption, and I'll report back on that next month.
Thank you, Glenn. Very clear, and the benefits are substantial. Any questions or perspectives to Glenn on that wide-ranging update? Julie?
Thanks, Glenn, and for the latest update that you've given us there verbally. There's just a couple of things. I thought it was an excellent report, as it always is. Regarding the challenges of flow and the work that's been done to support homes and domiciliary care, I just wondered if there was a piece missing there about supporting potential family in assisting in short-term care, whilst other things are going on, to actually support them to be able to look after their loved ones in the short term. And the other thing was, I welcome your involvement in the capital allocation process. I wondered if it was going to be the same sort of process with NHS digital and digital allocations for this much needed area of investment.
Okay, two really good questions. So absolutely, we should be looking at everything we can do to ensure safe home care, early discharge and admission avoidance, and supporting carers within that and families is a really important component of it. The worst thing in the world can be when a carer becomes ill, and often then 2 admissions are required to hospital. So there are a number of initiatives. I don't reference them here, but you're quite right to point to them to support carers and families. In fact, the My Sense project that I refer to, one of the things that provides is data to family members as well as to caregivers, so you can be reassured that your relative is going about their normal daily lives in a kind of confidence building manner. But no, we need to provide that support. And we heard this morning from our out-of-hospital teams about some of the initiatives that they're involved in. Turning to the capital allocations, so what I'm referring to in that review is the baseline capital allocations that go out to each individual organisation, predominantly based on depreciation of assets and asset lives. It was great to hear in the recent financial settlement that we've got additional capital for the NHS, and some of that is for digital. I was on a regional call with NHS ex-colleagues the other day, and the one thing I've asked them to do with digital is to speed up their approval processes for business cases, because obviously we want to adopt digital quickly, and some of the business cases and processes are quite slow at the moment. So it's not within the remit of this review, but they're very much being made aware of the need for us to have slicker processes that ensure that the additional resources have been identified can be deployed into improving our IT moving forward. So we'll keep a close eye on that one, and I'll probably report next month on the nature of those additional allocations, because there's quite sizable sums for digital, which is good to see.
No, thanks, Glenn, and thanks, Julie. Conscious of the amount we've got to cover today, we'll move on then to Jenny. Can you give us a Warwickshire North Place update highlights, please, Jenny? You're on mute.
Yeah, thank you. So obviously I'll assume the paper is as read. So the couple of highlights that I would just like to pull out is just to note the work that's been done in relation to the non-specific symptoms cancer pathway, because that's one of our newer developments within the programme, and also to update, since the report was written, that the local medical committee have come back and reviewed the proposals and are supportive of that. So that's a further update. So to note that. Also, just to note that at the end of the report, we've added some additional updates in relation to some of the progress and work that we've been doing, and that includes some to include sort of looking at personalisation as part of the projects and programmes of work, and that's sort of new in terms of adding into our programme, and also the fact that we are moving forward at Warwickshire North Place and within one of the PCNs with the population health management programme, and we are the first place to go live with that in Warwickshire North. So that's a specific piece of work that's new to the programme. The rest of the report details the sort of key highlights for each of the programme areas that we normally report on, and obviously the report gives the status in terms of our overall programme delivery. Happy to take any questions.
Thank you, Jenny. Jenny, it would be great if going forward we were to have something around the fragility or otherwise of our care home and domiciliary care providers in the places that we're responsible for. It's pretty silent on that, and to be honest, the fragility of social care as we enter winter is an enormous concern to me across all three trusts, in particular the fact that although the government's providing extra funding, roughly 80% of that's going into supporting care homes rather than domiciliary care providers. So if you could just give us a local update, that would be great. Questions on other perspectives, Glynis?
Thank you, Chair. Jenny, I know that a lot of these projects are in their early stages, but I'm just interested in at what point we might start seeing some impact of some of them. It's always helpful because there's a lot of work going on. It's a very complex programme, but at what point will we start seeing where they're starting to make a difference, and so you're thinking actually this needs mainstreaming or rolling out?
Yeah, so as you know, we're doing the benefits profiling piece of work, and that is progressing within each of the programmes and each of the projects, and they're all at different stages. We are hoping to pull together that as an overall sort of picture, and to be able to do a sort of prediction in terms of which projects will be delivering which benefits against a particular sort of forward view. That's in progress at the moment, and we haven't got a full comprehensive picture of that at the moment. But for example, we are bringing forward things. So for example, you've heard today about the DOCABO initiatives in the development session we had earlier, and that evaluation report is coming forward both for the care homes and for the DOCABO in the box. So there will be things that will come through at different time scales, but to give that sort of more comprehensive profile, that's something that we're working on as part of the benefits realisation piece, and is it still in train.
Thank you, Glynis. Thank you, Jenny. And Rebecca?
Thanks, Russell. Jenny, regarding workforce, what steps are we taking to assess the likely workforce profile or implications to deliver projects that go into business as usual? Where are we doing this, please? Thank you.
Okay, so we haven't got a specific workforce programme within our local place programme. We obviously identify workforce implications within individual projects as part of the sort of programme planning. In terms of primary care, we've got a particular focus around the additional roles, because that's a particular piece of work we're doing with the PCNs locally. There is a system focus through the people through the people teams, and I don't know whether Gertie wants to add anything in terms of those links that we have as a trust in terms of that, but we haven't got a specific programme looking specifically at workforce. We will look at it and pick it up in relation to particular projects.
Gertie, I'm too, it's a great question, Rebecca, worried about how on top the system is of understanding the workforce issues, particularly in social care. We did a piece of work in Hereford and Worcester, and what that showed was that the recruitment required into social care was 3 times the vacancy gap in the NHS. Is the head of people in the ICS producing a similar analysis, do you know?
Yes, Russell, actually, it's one of the areas that I've picked up as SRO under the People Board activity, and Therese is working with me on that. What we're trying to do is, and we've been working collectively across provider and health and social care, is to get exactly that, the baseline of where we are. So then we've got something to springboard off in terms of collaboration for apprentices and recruitment, etc. But it's about getting our baseline together at the moment, and that work is happening as we speak.
So it might be worth just reaching out to colleagues in Hereford and Worcester to see how they did it to save yourself time. And just quickly, Simone. Thank you, Rebecca.
Thanks, Russell. Jenny, you mentioned Optum under the population health management update. I wonder if at some point the board could see what this population health data is that the groups are looking at and what conclusions they're drawing, and linked to the previous question, what the implications are for workforce demand and supply and capacity, please.
Yeah.
Can I make a suggestion? That's a great question, Simone. Can we bring that back to a workshop? Because it would be good to get Duncan Vernon on the JSNA side as well, Jenny. But the way that those future trends and the implications of them, that's a great question, but is a big topic. Let's make sure we do it justice. Is that okay with you, Jenny?
Yeah, well, I was just going to say that specifically the Warwickshire North place focus with Optum is on a particular theme, and it's going to be around obesity and the links between obesity and diabetes. There is also, this has been commissioned by the ICS system, so Optum are working both at system, place and PCN. So I'm happy to link in the programme lead that's commissioned this for the system, of which we are doing the place and PCN part to it to support that discussion to take that further.
And just going back to what we talked about a second ago, it does worry me that our thinking about the future recruitment needs into place don't take account of the increasing acuity and greater therapy needs which are required as we become more effective at getting people home quickly. And that complexity, I don't think I haven't seen anything to my assurance which looks at that properly. So I think it's an important piece of work you're involved in there, Gertie. We'll move on then. Thank you for all the questions and your replies, Jenny. On the planning submission, Hack, please.
Thank you, Russell. The planning guidance was published late in September, but we've had some of the technical guidance being drip-fed through over the last few weeks, including the financial allocations. That means we haven't had time to work up a full planning submission to bring to the board here. But what you do have is a paper that sets out the key elements of the planning guidance, our key assumptions, and where we are aiming to get to with our plans over the next couple of weeks. So it should give a good basis for the submission that we intend to put forward in a couple of weeks' time. So in the paper, I'm asking for delegated authority for Russell and for Glenn to agree any significant changes from what is set out within this paper, because the submission is actually due on the 16th of November. The key to delivering this plan and getting through the next few months is going to be about looking after the well-being of our colleagues. I mean, that's of paramount importance. I know the paper doesn't touch on that because there's other papers and other work that does bring that to the fore, but it's also going to be about maximising our workforce availability, improving productivity and accelerating transformation opportunities, all of those things we touched on with the directorates this morning as well. And we're not starting from a standing start, so as you heard this morning, there's a lot of really great work that's been done over the last 12-18 months that have laid the foundations for all of those things for us to build on and help us to get through the next few months. This was a better financial settlement in the planning guidance than we initially expected. So the efficiency requirement is a bit lower than we were expecting, but we'll also get a share of some winter funding, which we weren't expecting to get. So there's £4.3 million of winter funding for the system, which is yet to be allocated out between the organisations, but we expect that to be done on a pro rata fair shares basis. And I think it's important to note that's on top of winter funding that's embedded within our allocation anyway. So there's nearly £2.5 million of winter funding already embedded within our allocation. the board agreed investment for winter of nearly £1 million. So the plan assumes that that'll get fully funded through this £4.3 million system allocation, but there's also some accelerated funding that hasn't yet been allocated out, so we'll get a share of that as well. So the plan does assume that our winter investment is going to get fully funded, but there is a risk that there might be a small shortfall, which I'm confident we can manage within the overall allocation. In terms of the activity planning, we did an initial activity submission mid-October. Because of the deadlines, that was based on effectively the Q2 levels of activity continuing, and so it's basically a holding submission really. So that was 95% of pre-COVID activity level was the assumption within the plan at that moment in time. The directors are working very hard on more detailed activity plans, and the aim is to maximise elective recovery, to maximise the number of patients that we see and treat in the second half of this financial year. We're aiming to deliver the key targets that are set out in the planning guidance, which are around the size of the waiting list and how long patients are waiting. Hopefully we'll be able to exceed those, but as a minimum we would expect to hit those targets set out in the planning guidance. There's also some additional capital and revenue funding made available through what's called the Target Investment Fund, and we have put some bids forward to that, which are at the shortlisting stage. We're just preparing the business cases for submission. And it'll be a few weeks before we hear whether we've been successful in those, and they're designed to help support our elective recovery. Now, in terms of the financial framework, that's broadly similar to the one that we had for H1, so block allocations, but there's been a significant change to the way the elective recovery fund income will work and the methodology around that. So that's based on completed referral to treatment pathways, or clock stops as they're known. So that's much more complicated methodology than we had previously. So it's much more difficult to determine exactly where we're going to land. At the moment, our assessment is that we will, in some of the months, we will get over pre-COVID levels of activity, but at the moment it doesn't look like the system will get there. Having said that, our partners are also doing exactly what we're doing, working through what additional activity they can get through. So we may get there as a system, but some of the feedback from the regional team is that many systems are struggling to actually get there in terms of earning additional elective recovery fund income. So there may be a review of the methodology, but we're not banking on that. So what we have been advised by the region is that we should maximise the number of patients we can see and treat, and be clear on the financial consequences of doing that and report that transparently. So that's what we will do. So I don't think it affects our plans in terms of the number of patients we intend to treat. There may be a financial consequence which will be accepted by NHS if we don't earn additional elective recovery fund income. So basically what we're saying is that the money is not going to, any money issues are not going to stop us treating as many patients as we possibly can. We're also required to deliver break-even over the full financial year, so we need to recover the £1.3 million deficit that we had in the first half of the year, and that's what we're planning on doing. That then means in terms of our efficiency requirement is going to be £4.2 million. Some of this we're delivering already as part of recurrent savings we've delivered as part of the first half of the year. So we'll need to find an additional £2.5 million in the second half of the year. The directors are working through their plans. They're about halfway there at the moment, and there's enough in the pipeline, I believe, to be able to get us over the line. So I'm reasonably confident we will deliver the £4.2 million target. Having said that, I acknowledge that that's a pretty tough challenge. I think in any year, let alone in a period where we're going to have a challenging winter. We're also required to reduce our COVID expenditure, and that's built into the plan, so nearly £500,000 reduction on there. But our current run rate is in line with that plan number. And in terms of risks, so as I said earlier on, the key is going to be workforce availability, but not just our own workforce. We already touched on domiciliary care and social care and other partners who will also potentially struggle with workforce, as well as any winter pressures on our capacity. So the above issues will impact potentially the recovery activity levels, but also have a financial impact. And there's also the inflationary pressure as well, which at the moment I believe we will be able to manage within our allocation. So just to round off, we'll continue to refine the plans and build in any allocation changes, which will be reflected in an updated paper to Trust Management Board. And I'm asking for delegated authority for Russell and Glenn to sign off any significant changes to this plan that's presented here before the submission date.
Thanks, Hack. Very comprehensive. Can I just ask colleagues when they're presenting to realise that in the allocated time I need to allow colleagues to ask questions as well. So if you're given 10 minutes, don't use 9 minutes 34 seconds up, and it causes me a problem. Very clear and very comprehensive, Hack. Questions and perspectives, Glenn?
That applies to me as well, Hack, so I took a lot of time earlier. So just to emphasise the point that you've made around elective recovery, because in discussion with national colleagues, I think we can expect to see, certainly from next year, but probably also from this year, that ability to pay individual organisations if they go above threshold, rather than applying the system level cap, which I think is really important. So you've made it really clear in the report, but we just absolutely need to track that issue throughout the remainder of this year so that we can make a case, if we need to, for what I expect to be some sort of regional pot to make that good. But right, I'm supportive of the plan.
Thank you, Glenn. And finally, Anil, and then we'll move on. Anil?
Yeah, thanks, Chair. Just to say, as Huck said, yes, it's going to be a tough ask. I think there are going to be quite a few challenges ahead, but actually, just to reassure the board, Chair, I sit in the Finance, Performance and Executive Committee, and there is a good amount of granularity, transparency and focus around the finances and the challenges there. So there is a reasonable level of oversight in terms of how we're going to get there.
Thank you, Anil. So, Hack, you're saying you're expecting us to break even for the year, given the financial settlement. You think the CPIPs are reasonable, although not easy, and you're asking for delegated authority if that's going to change very much. If you're not happy to grant delegated authority, please raise a digital hand. Okay, delegated authority accepted. Thank you, Hack, and thank you for your hard work. We'll move on then to the report on safe nursing and midwifery staffing. Daljit.
Yeah, thank you very much, Chair. I will take the report as read and just pull out the key points. I think the report fully describes some of the challenges we've had regarding staffing in terms of nursing and midwifery, and the mitigations that are in place that provide assurance to the board that we have kept our safe staffing levels. So September, we saw 20 day texts. 19 of those were no harm. There was one which was low harm, but to provide assurance to the board, that risk was identified and mitigated with staff moves. We're still seeing some good progress with staff using the Safe Care system, which enables real-time monitoring of staffing and recording of professional judgments. Of note, in September, we saw a slight increase in previous months on our staff absences associated with COVID, which aligns to the increase in COVID numbers in both in the community and in the hospital. So we had equivalent of 105 whole-time equivalent staff identified in that period that were off due to COVID. The report highlights that our current nursing vacancies and midwifery vacancies, not including Band 8A, is just under 50 whole-time equivalent, which is 7.4%. And for our healthcare assistants bands 2 to 4, the vacancy rate is 5.9%, which is just under 18 whole-time equivalent. The recovery and restoration, the theatre accelerator programme, and combined with the increase in emergency capacity, we are seeing additional capacity remaining open, which adds to the staffing challenges. Now, our first choice is always to use bank and to go through NHSP, but there have been times that we've required to go to off-framework agency, and we have a very strong governance process in place regarding that, which includes assurance that that particular shift needs filling, but also some risk assessments to assess any off-framework agency. I think of note of particular is that ITU have seen a particularly challenging month, and that's due to increase of activity and increased acuity levels across several areas to accommodate elective activity. You'll also see that ITU has appeared in the highest vacancies list. We've looked into the detail of that. It's just in relation to some healthcare support workers that have been business case that's been agreed, and a registered nurse vacancy, which they've had for some time, which they have been mitigating, but with the increased use of IT staffing, that is now being appointed to. To focus on midwifery then, very quickly, midwifery was also continued to be an area of challenge where maternity have had to continue to use the escalation policy and redeploy staff during normal working hours as well. The assurance to the board is that they've continued to provide one-to-one care 100% of the time in September. There were 34 red flags for midwifery, but they were all a result of not having a coordinator being supernumerary. But as the report highlights, in that case, a coordinator is not given a woman that's actively in labour, but is given other duties to complete. As highlighted last month, we recalculated our midwife to birth ratios due to an error that was noted. And you'll note in the table that we've done that back to January, and that shows an improvement in our midwife to birth rate figures, though we need to be mindful, as we've discussed in board workshop this morning, that our actual number of women that are registering with George Eliot to have their pregnancies and their babies there is increasing, and also we continue to see that sickness, which I've described in general nursing as well. That's the report really, and just to inform the board that I hope to bring the biannual acuity review to the December board meeting.
Thank you, Daljit. Any questions or perspectives to Daljit? Okay, conscious of time, Glynis.
Thank you, and thank you, Daljit. As always, this is a really gives me confidence about the monitoring and escalation to keep services safe in a very challenging time. Just a quick question about using off-framework agency, Daljit. Is that because we can't get the specialist skills we need from bank and NHSP, or is it just a general lack of staff out there?
It's both, Glynis. Generally a lack of staff. I think most organisations are struggling to fill through bank and NHSP on the background of some of the sickness as well. But if you look at some areas like ITU, it's also needing those specialist qualified nurses as well. Okay.
I'm fearful that over the winter, off-framework agency rates will go up significantly because they will see an opportunity to make a profit. Rebecca?
Thanks, Russell. Thanks, Daljit. A really clear and useful report. Quick question. Do we know what our conversion rate is, particularly for Band 5 applicants that are offered a post buyers and then subsequently take it up?
I don't have that information to hand, Rebecca, but the majority of, because they're newly qualified Band 5s, we tend to attract them, and the majority of them do tend to come with us, but we can certainly look at that for the next report. Unless Gertie has it on the tip of her tongue.
Just pop it into action points, please, Daljit. And finally, Gertie, thank you, Rebecca.
It was just very quickly to follow up on your comments, Chair, and Daljit around the use of off framework, is that we have recently set up a very robust and shared group with the Agency Use Programme Board, which looks specifically on a monthly basis at supporting the directorates around their bank planning, their agency uses. So I would hope to see, you know, some really robust support and challenge around any off framework use, and assisting those directorates to make better utilisation of their available staffing before having to move out. We've also just started a managed service provision with NHS professionals. So again, I'd expect to see our internal rates increasing through that. Thank you.
And Catherine, did you want to make a point?
No, I'm just ready for my next paper.
Okay, great. So on that subject, thank you. We'll move on to Catherine on mortality and learning.
All right, well, really great news. SHME is 102 within the expected range. HSMR is 88.8, which actually puts us among the best performing trusts in the country for HSMR now. And our weekend mortality rate is in line with expected. I just want the board to note that in Q2, 96% of our deaths were reviewed by the medical examiner, and the medical examiners are doing a lot more work in terms of communicating with bereaved families, talking through the death certificate, receiving any feedback, and I think that's a really important aspect of the service. I also want the board to note that we've done some SJR training to increase the number of staff who can do that. But really that the number of COVID deaths in Q2 you will see have increased from 1 in the previous quarter up to 17. And this is my public health message. Again, I say it every board, but I want to say it again. Yesterday, the Office for National Statistics published data showing that for aged standardised mortality, you were 32 times more likely to die from COVID if you were unvaccinated compared to those who'd received 2 vaccines. So again, I just want to say to the public who may be listening, to any colleagues out there who haven't been vaccinated, so important that we make sure we take up the opportunity to get both our vaccines and the boosters when offered. But yeah, I'm happy to take any questions on the mortality report.
No, fantastic. Thank you, Catherine. And any questions to Catherine? I remain horrified at how many, particularly younger people, are refusing to have the vaccination done. There is absolutely no logical scientific reason not to have the vaccination unless you are advised by a doctor, which is very rarely happening. So you should be getting your vaccinations done. We'll move on. Thank you, Catherine, for your help in helping us to catch up time. So the NHS England National Core Standards Report, Emergency Preparedness, Resilience and Response. Sounds like something a little bit from Dad's Army, but I know it's not, Stephen. Stephen, over to you.
Yeah, I'll take the paper as read, and in particular the title of the paper. There's just one
That's
item.
not 5 minutes, Stephen.
Yeah. There was just one item I was going to draw to board's attention. So we've submitted as substantially compliant. There's one issue which is detailed around the information technology data protection standards. We take that through the information governance group and are expecting that to be compliant in January. I'm happy to take any other questions.
Great. Any questions or perspectives to Stephen? Julie?
Yes, and thanks, Stephen. We're monitoring the position on the data toolkit through audit as well. I was just one question around, I wasn't quite sure how or if the standards have been adjusted to reflect the experience of COVID. I wasn't 100% sure.
No, they've generally kept them the same this time. So there's a lot of detail in of how we've responded, but the standards themselves haven't. So that's how we've got them. Okay, great. So just for clarity, Stephen, we're just receiving and noting this. We don't have to approve it? Yeah, just the board have got to be aware of it. So that okay. Does that. Any other questions or perspectives? Thank you, Stephen. So we'll move on then to the Trustwide incidents report. Back with you, Catherine.
Yeah, thank you. What I'd like to draw the board's attention to in this paper is the graph that's in Appendix 1, which shows a 3-year review of our incidents entered versus our overdue incidents. You can see through this that back in 2019, 2018, 19, we had almost as many overdue incidents open at any one time as we had incidents being reported. Our teams have worked incredibly hard at this over the years, and as you can see, we've now got the lowest number of overdue incidents open in the organisation. And what we should also note is, really reassuringly, an increase in the number of incidents being reported by our staff, which is really important for a strong open culture where people feel able to say that wasn't right or there's something we could learn from here. The rest of the paper mainly talks about the numbers of incidents and things like that. No never events, pleasingly, in this quarter. Really strengthened processes around the duty of candour, which recently went to the audit committee to show that we've really strengthened our processes around that. And the other thing that this report highlights is that we're undertaking thematic reviews where we see incidents that might be linked together. Examples that we've done in this quarter have been major obstetric hemorrhage, where we've reviewed a number of cases, and surgical site infections, because we see the value in learning from groups of incidents, and then really putting an action plan together to make the changes necessary to improve care. Happy to take any questions on this paper.
Thank you, Catherine. Really pleasing trends on that 3-year review. Any questions or perspectives to Catherine? Okay, great, thank you. So we'll then move on to the Guardian of Safe Working Hours report. Back with you, Catherine.
Yeah, this is a very short one. As you will see, in Q1, there were no exception reports. In Q2, we had 6 exception reports. I think it's just worth keeping an eye on gastroenterology, because 4 of those were in gastroenterology. And looking back to last year, that was an area where we had a number of exception reports. We have increased the staffing allocation in that area. We think this was due to a period of sickness, but we will continue to monitor this. This report should really be read in conjunction with the report we took to QAC at the end of October about the improvement that we've seen in our feedback from our GMC training survey. So I think both of these taken together show that we're trying to do a lot to improve the working lives of doctors in training and support all levels of staff in the organisation.
Thank you, Catherine. Any questions to Catherine on the Safe Working Hours report? And Daljit, on the poor Daljit, I know he's got a bad back at the moment, so thank you, Daljit. The Ockenden Action Plan Assurance report, Daljit?
Yeah, thank you very much, Chair. The report demonstrates the considerable work that's been in place to strengthen our assurance and our progress around Ockenden, the 7 immediate and essential actions. And the board's asked to note that just very recently we received an initial feedback assessment regarding our assessment that we submitted in June, and a high-level review of that indicates that we've got strong. We can say that we've got full compliance against 3 of those and partial compliance against 4 of them. But the real progress of these actions is evident underneath the high level ones when you look at the individual actions, and there is a sea of green in there compared to previously. So we're just in the process of reviewing all of those against our own evidence, and then we need to respond back to NHS EI by the end of this week on our review of those. And I think also important just to point out to board is that our own criteria we're using to assess ourselves is probably a lot more robust and stronger than the initial assessment that NHSEI have done. So there's areas that, you know, we've looked at that we want to further improve and add additional evidence to. So that's positive in the sense that when we actually look at the assessment that we've got back from NHSEI. In terms of the delivery plan that's in place, the vast majority of actions, as I said, are completed, and those that aren't have got a target time set. We're reviewing those very closely, and we're pretty confident that we'll be able to achieve most of those. There still remain some areas where we need action from either the LMNS or nationally in order to achieve those, and there's some where we're working in collaboration with the Maternity Voices Partnership to achieve some of those. But overall, the maternity team have done a really good job of making progress in these actions.
Okay, great, thank you, Daljit. And it's always better to be our own harshest critic, I think, in this type of area. Questions and perspectives, Glenn?
Certainly agree with that. And as Daljit said, no trust can declare full compliance because of some of those things that are external or national. Just on that point, Daljit, the point number 1, the enhanced safety criteria, are all trusts in our system in the same boat with that they're partially compliant because we need to put that arrangement in place within our LMS?
Yes, within the LMNS, yes.
Yeah, okay.
It's somewhat illogical if they weren't, wouldn't it? Yeah.
I haven't seen the returns of the other organisations because they've not benchmarked them yet. They've just given us a chance to review it. So haven't seen NHSEI's assessment, but certainly when it's discussed at the LMNS meetings, we're all in a similar position because of that.
Okay, I look forward to double checking that.
Okay, great. Any other questions on Ockenden? This will continue to come back to us, won't it, every month?
Correct, yeah.
Great. Okay, so we'll move on then to integrated performance report. Catherine, lead us by the hand, please.
Okay, well, I'm going to focus the board's attention mainly on what would be defined by the CQC under the responsive domain in terms of our operational performance, because these are the areas where we've got some of the biggest challenges at the moment. As I look out of my window, I can still see the autumn leaves on the trees, but it's starting to feel like winter in terms of the pressures that we and many other hospitals are experiencing. So obviously one of the first indicators of the pressure that we see in the organisation is the 4-hour standard, and that reduced this month to 84.2%. In June we were at 92% and it's fallen month on month since then. Now, as low as that figure would be historically, we're still performing better than many of our peers in this. And I think the one thing I do want to highlight out of this is the incredible work our teams have done around ambulance handover, because there were no ambulances at George Eliot waiting more than an hour to hand over patients. And you will have seen in the news the very significant challenges that other organisations are facing, and the WMAS was in the news for that. So our teams are working incredibly hard under challenging circumstances to try and deliver that. But we will not be complacent about that, because we recognise that means that there is a lack of access to treatment, and obviously that has an impact on safety for us. One of the things that we should note is that there's been an increase in cubicle capacity as the Trust has invested in changing the design of the department, and I'd encourage colleagues to go down and have a look at that, because the department is looking absolutely amazing. In terms of diagnostic standards, it's a similar pattern, unfortunately, that back in June we were reporting the best performance nationally in this field. That's dipped now to 90.7% in September. The key reasons behind that are capacity in MRI and ultrasound, and the team, as a short-term alternative, are looking at sourcing some extra capacity through WLIs and outsourcing, whilst a long-term strategic solution is developed. In terms of RTT, we've heard from our amazing theatre teams at the start of this meeting. What we've seen this month is a plateauing in the RTT performance, which is currently at 69%. Again, that's being impacted by some of the challenges we've seen about rising activity. But I would say that pleasingly, the number of long waiters continues to decrease and is now down to 486 people waiting over 52 weeks. As Hack's already referred to in the planning submission, we are aiming to have no patients waiting longer than 104 days on the cancer pathway from December 2021, and no 52 weeks by March 2022. Also, the stroke standard is another one that we've struggled with for a while, and that remains challenging, with 59% of patients spending 90% of their time on the stroke unit against the national standard of 80%. That is really quite challenging, and that's due to a combination of factors, which is full capacity, so operating at a high occupancy level, and also the need to swab patients for COVID and make sure that we are not mixing potentially COVID positive patients with COVID negative patients. In terms of our cancer performance, 62-day performance is variable. That's been down to an increase in the number of patients waiting tertiary referrals, which has led to an increase in patients waiting over 104 days for treatment. That's at 8 this month from 3 the month before. But really, although these are unacceptable for those patients, comparatively, that has been a shift in improved performance there, and our commitment to continue to reduce that by December continues. And the cancer 14-day target has been an area for celebration, with the breast service being the best performance in the country for any tumour site in August 2021. There is a risk there flagged about the increase in referrals for lower GI, which may put that at threat in the months to come. From a workforce perspective, although we've increased the headcount in the organisation, vacancies remain a concern. But what I do want to draw attention to, which I think one of our teams mentioned this morning when we thought about CQC well-led issues, is the core skills training framework performance is really excellent in the organisation at the moment, which again, on the background of COVID, the challenges we've got at the moment, I think our staff could be commended, and the leadership teams, for the way that they've just embedded that as practice as usual. And even we've seen an improvement in information governance. I'm not sure we're quite there yet, Hack, but we're in a whisker now. So a lot of work there. I think you'll notice on the quality dashboard, there's a lot of green there. There's one thing I just want to flag before I run through the list of all the brilliant things that we could celebrate. And that is that you'll notice that in September, there were no cleaning audits performed because of some staff absences in the hotel services. Dalgit would be happy to talk more about that, but there's a task force in place, and we're now seeing those have been resumed. So a lot of work been going in to pick up that, but obviously not something we wanted. What's on track? Well, our mortality, our falls, our pressure ulcers, statutory and mandatory training, MRSA screening, complaints response, VTE performance. I could go on, but Russell, I know that we've got a time pressure, so I'd be happy to take any questions on the IPR.
No, it's great, and I think the performance is always the output of the input of people's capability, competence, and drive. And what encourages me out of this morning's workshop and the results you just presented is our teams are starting to perform despite the very difficult challenges we've got. So well done to the executive directors for your leadership. So questions and perspectives, Rebecca?
Thanks, Russell. Thanks, Catherine.
You've muted yourself, Becca.
Yeah,
Someone had to do it today. So apologies. So within the report, it identifies that the staff wellbeing offers are being well publicised across the trust. So my question really is what has been our investment to date? Are we able to start to quantify that investment against initiatives? And also, how are we going to make plans to guarantee the stability and continuity of these initiatives?
I'm going to refer you to my learned colleague Gertie, who I think will give you a much better answer.
Thank you.
Possibly not. It's a great question, Becca, but to quantify the total investment is quite difficult. So, for example, the EAP is a service that's available for us at the moment through the Cobham Warwick system, which we haven't contributed financially to. We are moving to a new EAP, which will be the same EAP as South Warwickshire come the end of the financial year. And again, that doesn't necessarily come with a cost, but it offers a significant benefit. There are some areas where it's quite clear that we can show the investment. For example, the charities through NHS charities and the charity committee here have invested in a wellbeing officer's post, and we can start to really quantify some of the activity. We've agreed some objectives for that role, and we have committed to pulling together a business case based on the delivery of those objectives so that we can consider it through the usual BCRG route late December into early January, with the view to it becoming funded recurrently for next year, based on the outputs and the impacts and the developments of that role.
Thank you. I'm picking up from the National Guardians Network that there are organisations that are beginning to quantify their investment to underpin their evaluation programme. It would be great when we can start doing that. Thank you, Gertie.
Absolutely. We'll have a look at it, Becca, definitely.
I think the other thing is, and Rebecca, you were part of the Freedom to Speak Up and Wellbeing Cross Foundation Group meeting last week. We're clearly doing some great work, which is our Freedom to Speak Up, Ned, you're intimately involved in. So the well-being of our colleagues is disproportionately important at the moment. And as we both said last week, kindness and supporting one another, and I think I use the phrase holding one another's hands through what will be the turmoil of winter, is going to be absolutely essential for our teams to not just survive this winter, but to thrive during it. So we need to be kind. We need to remember that civility saves lives, and we need to support one another, because through those ways we'll be able to succeed. Any other questions on the integrated performance report? What's worrying you most at the moment, Catherine?
I think I'd have to say, so it's a toss-up between staffing and winter, and I think those are very intimately related. So our workforce, we've got a number of vacancies, and then the people who are left behind anyway are tired and been through a difficult period. So I think the resilience of the workforce is a concern. I think my second concern is that we're seeing rising activity levels. We're seeing high levels of COVID in the community, but that's also translating into more COVID patients in our beds. And that puts pressure on us, and the things that we've been able to really make progress on over the summer months in terms of our operating, our improvement in the RTT, our mortality rates, all of those things are related to our ability to keep our occupancy down so that we can have flow through the organisation. And I think those would be the things that we need to relentlessly focus on as an organisation, because that's the determinant between, you know, a green IPR versus a red IPR. And ultimately what that translates to is, if we can't get that right, that's worse outcome for patients, which is what we're so keen to get the best outcomes.
Yeah, great. I think as we head in, and that was a good list, as Glenn sort of referred to in the message box, ignore his comments, Catherine. But the thing which I think we're going to hit in the next 6 weeks, which we haven't discussed, but I would like just to ensure we pick it up as to whether it becomes an issue, is the issue of the mandatory requirement for care home staff to be double vaccinated by the 11th of November. I am still very fearful that that will have consequences on the ability of care homes to take our patients who are ready to go back to their care home, their ability to take them back, and therefore a consequent issue on bed blocking, length of stay, and other issues. Glenn, is there something you wanted to add on this?
Yeah, just on that point, we are expecting an announcement any day now on whether that will also apply to NHS and other care staff. And as you kind of implied earlier, it's hard to imagine why any of our staff wouldn't have been double vaccinated, but there is still the possibility that that becomes law for NHS workers also very soon.
Yeah, and I'd have to say that is an enormous risk factor as we approach the winter. Catherine, did you want to come back on that?
Well, literally to say that that is an issue for, you know, for any organisation, and the timing of that, if that does become, as we suspect it might, become mandatory for NHS staff, that will also have an impact on a workforce that's already depleted.
Yeah, no, and you know, just for the avoidance of doubt, everyone understands the importance of vaccination and double vaccination. My comments are in no way undermining that, but we do need to recognise the practicalities of life and the different risks and benefits of different decisions. And then finally, Gertie, and then we'll move on.
Thank you, Chair. It was just to follow up on that point as well. Mindful that we may anticipate an announcement around mandatory vaccination for our staff. Myself and the team within the vaccination centre have been doing a really robust review of our information around our staff, and we'll be able to clearly identify those who have today not informed us of a vaccine, if they've had it elsewhere, or who have chosen to decline it, so that we can offer them support and help and understanding. George Eliot's well known, and we've covered it here in the past at board, about running an additional allergy clinic, and we're running additional support clinics across the system. So in terms of us being ready to manage this, we will be ready in terms of a point when that announcement is made.
Yeah, and my fear isn't our capability to put jabs in people's arms. My fear is that a proportion of people just won't have it done. That's the issue. Okay, team, good discussion. Thank you very much, Catherine, for standing in for David. You do it so much better than he does. The finance report, hack. We've discussed the numbers already, but anything you particularly like to pull out?
Thank you. I can help to pull some time back here. I was only really going to just flag the year-to-date deficit already mentioned, so I won't say any more than that. And the additional information that's reported within the paper there around additional costs we've incurred to compensate for SLA non-delivery. So we've incurred £250,000 of insourcing costs in relation to oral surgery, where the University Hospital have been unable to provide the normal consultant cover that they would do for those clinics. I think it's worth noting that the activity levels set out in the paper aren't comparable to the activity levels that would have been provided under the SLA, so significantly higher levels of activity. So it's worth bearing that in mind. But we can provide that information next time to make it more to give a better comparison between what would have been done under the SLA and what we have here. The only other area I was going to mention was capital expenditure. It's increasing. We're still behind track. We have some risks around delivery in terms of risk of slippage, but also significant inflationary risk in our big building projects. We're monitoring it closely, and I expect to be able to manage within our capital allocation. I'll leave it there and take any questions.
No, great, thank you, Hack. And I think that visibility on the SLAs is important. It is essential for our tertiary partners to perform if we're able to provide the best health outcomes for our citizens. Questions to Hack? Rebecca?
Thank you. Thanks, Russell. Hack, regarding the oral surgery, it's great to see the improvements that we've made. As a layperson in this respect, it's difficult to understand how it is that we've ended up to making an investment ourselves rather than our partner doing that to provide a service to our patients. My question is, are we still paying for it, or is that investment now finalised, and what's the next step with it, please?
I think it's important to understand kind of how the SLA works. So under normal circumstances, the University Hospital would provide the consultant staff to support these clinics, and under the current circumstances, they're under the same kind of pressure that we're under. They're able to provide that consultant support. But for us as a trust and as a system, the important thing is that we treat as many patients as we possibly can. And we've been funded effectively for this activity through the recovery funding. So it didn't really matter who paid for the additional cover, just as long as we treated the patient. So we haven't necessarily ended up worse off financially by doing this ourselves. And in terms of, yes, we're paying for an SLA and not getting a service, but that's accounted for with the way the block contracts work. So again, we're not disadvantaged from that perspective either. So financially, we haven't been disadvantaged, I think, is a short answer.
Thank you.
But there is something perverse that you get paid for an SLA when you don't perform as a tertiary. Glenn, did you want to pick up on that?
No, I completely agree with Hack's analysis, but it just kind of reinforces how important it is for the NHS to go back to some proper financial discipline soon, because there's currently very little connection between income and expenditure and accountability. So what we need to be ready for is going into next financial year and having a really clear service level agreement with UHCW that if additional activity is required, that it falls on them to pick it up if they've not delivered it through the contract.
No, absolutely, Glenn. And it's why we set up the foundation group, was to identify and share best practice at pace to drive productivity. And the work that's going on, building on GIRFT with our own PACE programme, evidences our desire to be as efficient as we possibly can be. And when you look at our reference costs across the foundation group are very pleasing. I'm disappointed that the discussion about model hospital and reference costs is sort of dropping off some people's radar at the moment. And then finally, Simone.
So just on that theme then, I'm a bit confused about where accountability does lie at the moment for holding UHCW to account for performance. So could you just help me with that, Hack, now, please?
Can I just help a little bit, Hack, before you say something? The primary responsibility for any organisation's performance is its own board. So I think that's an important contextualisation. Hack, is there anything you want to add to my sort of diplomatic reply?
Yeah, I think it's linking back to the point that Glenn made earlier on in that we've got we are operating under a performance and financial regime which is not the norm because of COVID. So the financial framework we're getting as a system getting funded to do to see as many patients as we possibly can. So the focus is on seeing as many patients as we possibly can as a system, and the money is largely following that. And we're also we're not being disadvantaged in terms of financially from the fact that some of the SLAs at the moment aren't performing. The key point here is really going forward as part of an ICS, and as we move into the new financial year, that we do have really clear governance, because actually the direct answer to your question would be, at this moment in time, the governance, if we were operating the normal regime, the governance across the system probably wouldn't be strong enough to address those kind of issues that you're flagging.
Yeah, we will no doubt come back to this over time, but thank you, Simon. Colleagues, happy to move on. So we've then got the summary of ratified policies.
It's hard to string this one out, Russell. There were 5 policies ratified and the details of them are included in the paper.
Oh, that's great, thank you. This is for receiving and noting. Any questions on the ratified policies? Can't see a digital hand, so we'll move on then to the maternity incentives. This is the second longest title, I think, today. The Maternity Incentive Scheme, Clinical Negligence Scheme for Trusts, brackets MIS, CN, ST, close brackets, report quarter 2, 2021-22. Daljit, I blame you for that title.
Well, no, thank you for saying that, because I'm going to shorten it to MIS and CNST. So you've just told us what it means. So the report really highlights the fact that in August, this is year 4 of the revision of the standards. In August, the new guidance was issued, and then we discovered that this was amended again in October. And it's for this reason I'm unable to bring a position update in relation to quarter 2, because we're going through that thoroughly. What I can assure the board is that we've reviewed the governance structure surrounding this, and have introduced a tracker, evidence tracker, similar to what we're doing for Ockenden, but also put in some operational delivery and steering groups as well, so that we'll have close oversight on the evidence that's been submitted for the CNST. I anticipate that we'll be able to bring a full picture to Trust Board in February, but just to assure the board that we will monitor our compliance during this time at these meetings and escalate anything to bring it to the board's attention should that become apparent during this time.
Great, that's great. Thank you, Daljit. Any questions to Daljit? Okay, could I just ask everyone to make sure they're on mute unless they're a member of the board and they're talking? Thank you. So we then move on to the subcommittee updates. The QAC from the 27th of September, which we've talked about before, I think, and then the 25th of October. Glynis?
Yeah, thank you, Chair. Yeah, we had a very busy meeting as usual. On this occasion, we weren't quorate, but there were no significant decisions to be taken, so it was not an issue for us. Just a few points to flag to you. Firstly, maternity. In addition to getting the dashboard, we are also doing deep dive reviews of particular areas to give us assurance, and we received that report on perinatal mortality this month, and I can assure the board that we took a good degree of assurance on that report, that all the cases have been appropriately referred and reviewed, and following that no issues have been identified with clinical care that would have made a difference to any of the outcomes. The other review that we received, as Catherine's mentioned, was to do to postpartum hemorrhages. Again, 13 cases have been reviewed and no single theme was identified from that, which was assuring, but any learning from the case reviews have been embedded in practice. So those were really positive reports that we received there. And just in terms of staffing, again, Daljit's covered the challenges with staffing in maternity, but QAC endorsed a recommendation that we delay the rollout of the community continuity teams until early next year, because the additional pressure that would put on the service at the moment would potentially compromise our safe staffing. So it's just paused at the moment. We've got 2 teams and they'll be picking that up early next year. The other thing to mention was the continued challenge we have with ensuring that stroke patients spend the majority of time on the stroke ward. We've also reviewed the SNAP data to do with stroke, and we have requested an improvement plan comes back that takes account of getting it right first time programme, the SNAP stroke outcomes, and also the key targets, so that we've got a robust single plan around stroke. Let me have a look. Oh, and one final thing just to make board aware of, and that was to do with radiology. There are a number of outstanding actions in relation to the improvement plan for radiology, but that was slipped because of the COVID pressures. But we did take assurance there's no significant patient safety risks related to this, and that they're now progressing and will receive an update back on progress in the future. And I'll give a full written report to next board.
Super, thank you, Glynis. Any questions or perspectives on either the minutes or Glynis's verbal update there? Okay, Glynis, thank you, and thank you for everyone's hard work on quality assurance. I think therefore we're on to any other business. Please raise a digital hand if you have any other business. Okie dokie, so well done team. Like I said, a very good morning this morning. Sarah, do we have any questions that have been submitted from members of the public?
We haven't, Russell, no.
Okay, so we've got a few minutes. Would any members of the public like to ask a question? Please raise a digital hand or come off mute.
Good afternoon, Chair. Again, a really good board, lots of good initiatives going on. I would just like to take this opportunity with COP26 going on about the Trust's carbon footprint. It does get, I think, discussed at annual general meetings in the report, but it doesn't seem to be monitored throughout the year. I'm sure it is, but I've not noticed it come to Trust board. And what's the Trust perspective on that? Okay, thank you, Natalie. It is a subject of comprehensive debate for us board with the estate strategy and everything else. But Glenn, your comments, please.
Yeah, it's a good question, Natalie. There's also planned to be a local event across Coventry and Warwickshire that will be look at similar things with some of our local authority partners. In July, we approved a sustainability strategy for the organisation, which came through board, which set out some ambitious plans in order to reduce our carbon footprint. The NHS is quite ambitious on this too. I think over the last year, we've gone backwards a little bit with all the PPE that the NHS has used, and so it's kind of raised the agenda even more. So we're doing some work across the foundation group and sharing some best practice. So at our next three boards discussion, our next foundation group strategy committee discussion, we're looking at the heat pump installation in Wye Valley and some of the things they're doing there to see if we can learn from that. Over in Swift, during the summit, we've got staff coming up with ideas about how we can reduce our carbon footprint, and those will be shared across the group also. So there's quite a lot going on. You're right, though, probably what we ought to be thinking of in terms of future regular reporting is a mechanism through which we can keep our eye on some of those ambitious targets that we've set that come through our board performance pack. So we'll have a look to see how we can do that. Some of these things are not easy to do on a regular monthly basis, but let's see what we can do to demonstrate that we mean this, which we certainly do as an organisation.
Yeah, it's good to hear that. Thank you.
Thank you, Natalie. And Stephen, was there anything you wanted to add on that?
Yeah, just to build, following the approval of the strategy that we've had at board, so there's a regular update now going to TMB. There's one scheduled in the beginning of December. It normally went through the estates group, so it'll come through that route to board in the quarterly update. At some point it will change though, because I don't think it's just about estates. But picking up on what Glenn said, that's the bit we'll work through. But there is a governance route, it will come through, you just won't see it every month.
Right. Thank you.
And I can't see any other hands up, so I'll draw the meeting to a close with thanks for everyone for joining us, and look forward to seeing you at the beginning of December. There's one more board before Christmas, so it will be a digital board again. For board colleagues, I suggest we reconvene for the confidential board at 3:30. But in the meantime, can I ask everyone to take care? If you are offered a booster, take the opportunity of a booster, and certainly if you're not already vaccinated, please do so. It's part of your social responsibility to look after those you care to have a vaccine. Thank you very much.